Welcome to Grand Rounds. I have the privilege today of introducing our speaker. My name is Dan Hunt. For those of you who don't know me, I'm the Division Director of Hospital Medicine. Twice a year, we invite a nationally prominent figure in hospital medicine to join us as a visiting professor. And I have to give kudos to our Education Council, led by Dustin Smith, and to our working group, led by Michelle Sundar, for arranging today's visit. So our speaker today is actually Dr. Michelle Mourad, who is, I'm going to read some of her titles. It's a long list. Vice Chair of Quality Improvement and Value, Department of Medicine, the University of California at San Francisco. Director of Quality and Value Improvement Research, the Division of Hospital Medicine, UCSF. Associate Professor of Medicine, UCSF. Director of Transitions in Care. So she does an amazing portfolio of activities. Clinically, she attends on the teaching service at UCSF and also attends on the procedure service, and we've had some interesting conversations about that over the course of the morning. Her interests in quality improvement are really broad, and they include transitions in care, patient and provider satisfaction, reducing cost of care, using informatics to improve care delivery. I think we have interest in all of those as well, so we're really looking forward to this talk. And I'll give one more intro. Michelle has won a ton of teaching awards at UCSF, so we're really looking forward to this. Dr. Mourad, thank you.
Thank you. Thank you, guys. I'm really looking forward to being here. I'm just going to test that my slides advance. Excellent. It is a pleasure to be here at Emory and get to speak to all of you guys today. I've had a chance already to meet with a number of faculty, and really the challenges that we're experiencing at UCSF resonate here, and the more we can sort of form collaborative partnerships to navigate those challenges together, I think the better. At UCSF, we have a tradition where we ask Grand Round speakers to spend a little bit of time of the intro telling people, well, how did you get here? So, I have no disclosures. How did you get here? What has been your career path? What are the epiphanies, relationships, experiences that have shaped who you are today? And I was pleased to see in the Grand Rounds introduction that you guys have a similar tradition here. So, by way of doing that, I always ask my trainees, when you meet someone who is influential in their field, ask them, what do you spend every day doing, and do you love it? So I would love all of the trainees and junior faculty to go through a case with me as a sort of career-finding exercise and as a story to tell you how I got interested in quality improvement. So you are taking care of an 82-year-old man, class 4 systolic heart failure. He has an EF of 35%. He's admitted for hyperkalemia and AKI in the setting of decreasing oral intake, over-diuresis, and enalapril. Now, you hold his enalapril, everything resolves, you get him back on a lower dose of his diuretic regimen, and as you are nearing discharge on rounds, you wonder, should I be using an angiotensin receptor naltrexone inhibitor like subcutaneous valsartan to decrease mortality and minimize risk of hyperkalemia? Or perhaps, how will I ensure that he stops taking his enalapril at home and restarts it at the right time? Maybe you're thinking, will the discharge summary really reach the primary care doctor? Or my favorite, has anyone had a goals of care discussion with this patient? And I remember being on rounds and talking to my fellow residents, and they all were thrilled to be on their consult months, practicing cutting-edge medicine without having to do that thorny task of discharging a patient. And I, on the other hand, I just didn't get it. I said, well, who doesn't love a really great discharge plan? And that's when I realized that I actually was probably not going to subspecialize, and that hospital medicine was really a field for me where I could, in that time, if you wanted to do work in quality improvement, you really were a generalist or went into hospital medicine, and that is changing. There's so many more increasing roles for quality improvement in the subspecialty arena. But it always struck me that we spent so much time thinking about these evidence-based decisions, weighing the literature for, really minute clinical benefit, when we weren't really thinking about the bigger questions, like, will this patient's primary care doctor 40 miles away know my brilliant care plan? And will my patient actually go up and pick his up at the medication? And will it be covered? And so for me, as I thought about practicing evidence-based medicine, and don't get me wrong, I love evidence-based medicine as much as the next gal, but I really asked myself, well, where in evidence-based medicine, where in this triad that Sackett put forth in the BMJ of individual clinician expertise, best internal, external evidence, and patients' values and expectations, well, where is this idea of effective implementation? And that is really what interested me as a resident and as a junior faculty to think, well, my job is not only in evidence-based medicine, but my job is to make sure that evidence-based medicine is implemented effectively. And so that is how I've tried and shaped my career. The credit for this slide and this graph goes to Vikas Parekh, who is the Chief Quality Officer at University of Michigan. And he really says, we have done amazing things in medicine through evidence-based medicine. We have improved outcomes dramatically, patient outcomes over time. Now, there's just one problem. Maybe it's different here at Emory. You guys are an amazing institution, but at UCSF, we don't implement best practices 100% of the time. We don't. And this gap between what we know we should be doing and our ability to actually do it and carry it out through our very complex healthcare system is what people call the implementation gap. So I would like you to turn to your neighbor and just try and answer the question for me of why? Why do we have this gap? And I'll give you guys a minute at our other hospital sites. Turn to your neighbor and just say, why do you think, what are some reasons why we have this gap in our healthcare system? Great. So whatever your answer was, you're probably right. There's so many reasons why we have that gap. Whatever you came up with, I'm sure that was one of the factors that's going on. I'm going to argue that we don't spend enough time doing that. We don't spend enough time saying, hey, why aren't we practicing perfect medicine? Why aren't we implementing our evidence 100% of the time? Why aren't these people who go to this 24-hour fitness in LA losing any weight? We just don't think about taking a pause when we have our problems to really work to understand the problem. And so what I want to do with you guys today is think about how do we bridge that gap and go through some stories and examples of how we have tried and how we have failed in the past to bridge that gap, because we really haven't spent enough time thinking about why we have problems in the first place enough to be able to fix them. My QI portfolio dark closet is filled with failed QI interventions that I've learned a lot from. And so is the national landscape. Some of my favorites, slides advancing on their own, some of my favorites are the campaign to have patients ask providers to wash their hands. Now, with the problem of hand hygiene, who thought that it would be a good idea to foist this responsibility for washing their hands on the backs of our patients rather than us figuring out how we should do it ourselves? Turns out this was wildly ineffective, and the number of patients who actually asked their doctors to wash their hands across the country was probably in the single digits. It just didn't work. It wasn't a solution that met the needs of the problem. Another one was that we failed to understand how we could properly address pain control in the hospital. And a good solution was, why don't we just incentivize doctors through the HCAHPS scores to, I think the wording is, do everything they can to help you with their pain. That is not a good solution to our problem of pain control in the hospital if doctors are incentivized to do everything they can to help their pain. That is a solution that just does not match the complexity and the needs of the problem. And then another one of my favorites, since I do love a good discharge, admittedly, was our attempt to think about readmission risk without thinking about factors like patient function, illness severity, and social determinants of health. We thought that we could just come up with risk prediction scores based on Medicare claims data and then affect those risks through our preventive methods without really thinking about who this patient was and what is life like in their environment. Our solution to readmissions did not often address the social determinants of health and did not assess the functions of the patient and did they have a caregiver supporting them through their health care. And we've learned a lot from our inability to improve readmissions about what is actually the driving factor of readmissions that we did not understand early on. And it has been said that, shockingly, healthcare is a very complex problem, as it turns out. I think our president was quoted saying, actually, it turns out healthcare is very complex, something everybody in this room has already known. How many people know what this is? Show of hands. Anyone want to say what this is? Yes, so this is a Rube Goldberg drawing. Rube Goldberg was a famous engineer turned cartoonist who delighted in depicting very simple things through very complex mechanics. So here, this is an automatic napkin wiper triggered by this gentleman taking a bite with his spoon. You go through a series of mechanics that involves parrots and crackers and ultimately a lighter lighting a rocket and cutting a sickle to release the napkin to swing on a pendulum back towards his mouth. And I bring this up because sometimes this is what healthcare feels like. Whether it's medication reconciliation or admitting a patient or getting a referral from an outside facility to have the patient seen in the subspecialty clinic involves multiple steps. And I think too often in quality improvement, we have looked at our narrow view of the problem as a clinician and said, oh, I know, well, if we just add another parrot, we're going to fix this problem. And we haven't taken that step back and said, oh, maybe this problem is bigger than I thought, and to really solve this problem, I have to take a couple steps back. And in really asking the question, why do we have this problem in the first place, we can much better come to a solution. I love to engage trainees in quality improvement. The challenge is escaping the danger of low-hanging fruit. And it's really easy to think, okay, well, I'm just going to create a quick fix. I just want a short-term solution to this problem. And we end up things like, this is our EMR banner, which is so woefully crowded with information. Everybody now ignores the banner because everything is too small to see in it. And the natural solution for anything people want to know as soon as they go in the chart is like, oh, well, why don't we just put a field for that in the banner? But everything is, woefully crowded there. Or my favorite is, I went to the chief residence and I said, hey, can you give me all the pocket cards you have out on display now? Because the solution, the first step of every quality improvement project at UCSF is to develop a pocket card for the residents to keep in their pocket. Or, as we all are very well familiar with, is, well, if providers aren't doing what you want in the EMR, why don't we just create an alert? And what we know is that when you bombard your physicians with these low-hanging fruit solutions without addressing the big problem, you actually do everybody a disservice, because this is the kind of noise that keeps us from really solving our quality improvement challenges. So what should we be doing? Where do I want us to go? To fix the gap, I want to introduce you to my favorite framework that I use when I'm tackling a quality improvement project, and it's the four-legged stool. And each leg of the stool represents something that without which your quality improvement project will likely fail. I did an experiment. I was on service the 2 weeks before I came here, and I kept a little note card in my pocket. It was not a pocket card. It was a blank note card in my pocket. And I wrote down every time someone said, we just need to teach the house staff that. Goals of care conversation before skilled nursing facility. Telemetry, turns out, doesn't help in GI bleed. Using normal saline in critically ill patients might not be the best idea. Follow-up appointments should be made within 2 weeks unless the PCP and the heart failure and the COPD. And use the delirium order set if your patient's freeze positive for delirium. And I think the inclination is, well, people just need to know more and they need to work harder and they need to remember. And what we know is that education is not a really great long-standing intervention if you're thinking about quality improvement. And I'm sure Wendy has seen this curve many times. This is the Ebbinghaus forgetting curve. And it looks at how long we actually retain information over time. And even with a perfect lecture, where you, leaving the lecture, you're like, I could recite that lecture myself. I know 100% of what I was taught. 6 days out, you only have 25% left. And you multiply that across all the hospitals where our trainees work and all the different EMRs they use and all the different initiatives at every other hospital, and you realize that saying, if we could just teach the house staff that, is not going to be a foolproof way to do quality improvement. This was borne out in the literature. This is a very early study when many of our quality improvement initiatives did involve educational campaigns and conferences and protocols and policies. And they actually had 102 trials of interventions to improve professional practice. And they looked at the sustainability of the interventions and the rates of sustainability and or changes, even short-term changes in professional practice based on these largely educational-only interventions were very low. My favorite story comes from one of my friends who is the medical director for education at the University of Arizona in the Department of Medicine. And at their hospital, they had a blood transfusion utilization campaign that was coincident with Orange is the New Black coming out. So they came up with what they thought was a brilliant campaign. One is the new two, trying to get everybody in the hospital to order 1 unit at a time, recheck the hematocrit rather than 2 units. As you can see, the campaign was a great success. Just until the strategic initiative changed. And then after that, they went almost back to their baseline levels. And it was because the campaign was really largely focused around education and this mantra that while it was in vogue, everybody was saying it and doing it, and as soon as it was no longer present, disappeared from their consciousness. So, I'm not going to say education is not a pillar of quality improvement. Education is essential. People need to know, especially the why that this matters, as well as how we plan to tackle the problem. But, no one likes sitting on a one-legged stool. So, everybody really thinks of QI synonymous with system change, right? You got to make the easy thing or the right thing to do, the easy thing to do, separate these two buttons like this is clearly a system that is designed to fail. But what does that really mean? How do we effectively change our system of care? And so often, this is a great quote from Eric Topol, who is a cardiologist at the Scripps Institute. Right now, everybody's solution is, well, it's all digital. It's all about our EMR. So it's worth taking a pause and saying, well, how has that gone for us with making changes in our EMR? We have had amazing EMR adoption. This has probably been the fastest change in our healthcare industry is the widespread of EMR adoptions through meaningful use. And you can tout this as a great success that we have managed to get EMRs into so many hospitals across our country. But has it worked? Has it really changed care? Sometimes, yes. This is a great example of how sometimes in the right setting, a pure system change can lead to dramatic results. So this is from Penn Medicine's Center for Health Innovations and Behavioral Research, where they did the very simple thing of, in their outpatient prescribing menu, they flipped the brand and generic. Before the brand were on top, people would click the first core egg they saw. They flipped it so that the generic were on top. And look what happened to their rates of generic prescribing. They went from an average of 75% generic prescribing to 98.5% of generic prescribing. There was just one medication that didn't go up. Anyone want to take a guess on what that medication is? Not quite. Not warfarin. Yes, exactly. Because there was enough culture and enough lack of buy-in in generic that even this system change was not enough to make all those endocrinologists who are like, oh, my patients have told me and studies have shown maybe the generic is not equal. But I was going to name names. But, I wish we saw results like this with every EMR change that we put in. But unfortunately, we haven't seen those early results. Our early results, at least speaking for UCSF, is that we built these fabulous order sets that have all the evidence-based practice that we want people to do, and we only use 10% of our order sets. Only 10% of all the order sets we built have gotten used. We are so judicious with our alerts. There is an alert committee where you have to prove to them that there is no other way to get the behavior that you want other than alert. And still, we looked at how many alerts a full-time practitioner sees in their day. And for pharmacists, it's even worse. So we have tried to create an alert-free environment, but still there are too many important things that we want to signal to the physician, but we know that the majority of alerts are just bypassed through without physicians actually doing what you wanted. And then there's limited actual decision support. An alert is not helping a provider in real time figure out what they want to do. And so that was the promise of meaningful use, is that we would be able to bring best practice evidence to the clinician as they're making that decision. And we haven't really followed through on that promise. And many physicians actually see their EMRs as just this time sink black hole that keeps them from seeing their patients at the bedside rather than something that really enriches their care. So we need to do better. The literature supporting this, this is a great study from the Canadian Medical Journal that looked at when providers do get pop-ups, when they have best practices such as, hey, you might want to redose this medication for the patient's creatinine, or did you know your patient is now due for colonoscopy screening because of their age? They said, well, how much improvement did we see when we implemented that alert? And the thing is, most of these studies, if you read the conclusions, they say we were able to demonstrate improvement in our desired outcome of physician-provider practice. And then the thing I love about this study is they said, well, okay, that's great, but how much? How many more times did you order a statin when we asked you to? How many more times did you actually change the dose? Or how often did you blow by this alert? And losing the median outcome from every study, 4.2% in a practice change. So if it was previously at 60% before, after their study they were at 64%. And even if you looked at the best outcome from every study, it only reached 5.6%. So we're doing something wrong. We're not reaching clinicians in the way we want through our computerized alerts. So we are getting smarter, and our EMRs are getting better. Some of the things I'm working on at UCSF is, I know you guys are working on telemetry discontinuation here. We are piloting a randomized control trial of different screens when you order telemetry and different responses when telemetry is supposed to expire. So we now have, when you order telemetry with an indication. And half of the people are randomized to an alert that says your telemetry is going to be auto-discontinued, unless you reorder it now. And half of them are randomized to, here is the order to now discontinue your telemetry. Do you want to discontinue it or not? And we're looking at really trying to study and understand, well, we're not ever going to get away from alerts, or we're not going to get away from trying to use the EMR for decision support. But how does it actually work for physicians? How do you get them to click on what you want to click on, or actually read the alert? And so that is a really interesting field of study that I'm involved in at UCSF. Another thing we're doing is using predictive analytics to deliver better order sets. So we went down a huge rabbit hole with our translational science researchers of trying to figure out, can we, based on an emergency department's ordering of nebs, steroids, combination of the problem list, basically looking at that patient's chart and history, and can we predict whether they're hospitalized for a COPD exacerbation before someone writes the core admission orders? And then in their core admission orders, when they pull up the core admission order set, it gives them a little addendum that says, hey, we think your patient, based on their their ER course, we think they also might have COPD. So we have hand-delivered this order set that you may not have even known existed. We're hand-delivering it, and we're going to attach it to your core admission order set. And if this is successful, we'll do this for other order sets and thus try and create pathways. And this order set not only has the recommended dosing of prednisone for a COPD exacerbation, but also has things that are really hard to get every practitioner in your hospital to think of, like, are you referring to pulmonary rehab? And did you know we have a pulmonary quality of life clinic that specializes in improvement of dyspnea through a multidisciplinary team, including palliative care? These are things that you cannot teach, but through a very smartly delivered order set, we might be able to make some traction. And for those of you who are passionate in transitions in care along with me, a big focus is, well, who are our community partners? And are they really carrying on our discharge plan for patients who are hospitalized under our care? And we have done the same thing with our order sets to skilled nursing facilities and home health facilities, where we have asked the EMR, hey, if this person has heart failure, COPD, or delirium in their problem list, or as one of their admitting diagnoses, when the provider pulls up the skilled nursing facility order set or the home health care order set, can you deliver them a specialized order set that will change the care at the skilled nursing facility or change the care in home care? So I don't know. Maybe these will work, or maybe they will fail like every other intervention, but the EMR has the potential to be such a powerful tool in guiding clinician behavior. We just have to figure out a way to make it work for our very busy and overworked clinicians. And then there's a whole other universe of system change that I know many people are engaged here at Emory, and that is, how do we deliver people differently? And how do we go out into the community to reach people where they are? At UCSF, we have a very robust Office of Population Health, which I'm a part of through my transitions in care role. And our thought is really, we've looked at the hospital as the locus of control and of touching patients for far too long, and that really our locus of control needs to move into the community. So with all of our alternative care models, how do we instead stop saying that the hospital is responsible for all of the outcomes and the hospital is responsible for guiding the care, and how do we move that into the community and be more proactive even before that person comes to the hospital? So I was so pleased to see and hope to get to meet some folks from the Urban Health Initiative about how they're really looking at patient engagement, putting community workers into the environment for patients, and really changing the system of care in that way. So 2 big pillars: can't do it without education, can't do quality improvement without changing the system. But I'm going to argue to you that still is enough. We still need 2 more ingredients to really make sure that we are delivering best practice 100% of the time. To do this, I'm going to ask you guys to take a test with me. It's just a simple test. These are the only 4 cards you need to know. Each card has a letter on one side and a number on one side, and you are given a rule. If a card has a vowel on one side, it has an even number on the other side. That is our rule. All right? Now, which card or cards must be turned over to determine whether or not the rule is followed? Okay, I'm going to say everybody is probably pretty sure that A needs to be turned over. So I'm going to ask you, how many people think A and D? How many people think A and 7? How many people think A and 4? Excellent. So it turns out 90% of people get this test wrong because they want to say A and 4. They want to confirm that not only does A have an even number on the other side, but 4 has a vowel on the other side. But it turns out the rule doesn't say if you have an even number, there's a vowel on the other side. It just says if you have a vowel on one side, you have an even number on the other side. So the right answer is actually A and 7. And this is a great example of why we need data. We are programmed to think about, to find data that reinforces our belief in what we know. We are, when we watch the news, we are searching for data to confirm our worldview. The same thing is true in quality improvement. If I think I am a, brilliant physician, I am looking for any data in my world to confirm the fact that I am a brilliant physician. And we actually need to put data in front of people that challenges their notion of the care they provide. And doing so is incredibly powerful. If you are motivated and heartfelt and want to do your job well, and you are confronted with data that shows that you are not practicing up to your standards, that is a huge, powerful motivator to change. There's just one problem. That data needs to be valid, and you need to feel like you own that data, those data. And that's something that we have really struggled with in healthcare. And so this may be one of the reasons why audit and feedback has not been as powerful, why showing physicians their own data or showing them data of their group has not been as powerful as we wanted. It turns out audit and feedback is a strategy of let me gather your data and then show it to you has not been as effective and has only led to, in a Cochrane review, has only led to even modest improvements in performance. We have struggled with this on a national level as well, to find those measures that are really a valid measure of how people think they're doing. And to illustrate this challenge, I'll tell you a story from about 10 years ago when CMS was really looking to pay for quality, not pay for performance. And they said, what is a measure that no one can disagree with, that everyone will rally behind, right? Who doesn't rally behind helping our patients quit smoking? That is like so important to their health. You look at the health benefits over hours to years of quitting smoking. And of course, we'd like to create a quality measure around helping patients quit smoking. We can't measure how many people quit smoking. It's too hard. It's too daunting. So what did we do instead is we said, well, okay, what is an analogous process measure that we can create to quitting smoking? Oh, I know. Let's incentivize hospitals to counsel patients on quitting smoking, right? And, you know, this is the challenge of having challenges in measuring outcomes is you find your next best surrogate process measure. And it pains me to say that UCSF's first solution to this was this. It was a checkbox. If you smoke, stop all smoking and tobacco use. Did we meet our smoking cessation counseling measure for every patient? Yes, we did, and so did every hospital in the country. Everybody was at 100% for smoking cessation counseling. And you know, this is one of the fundamental challenges of audit and feedback and quality improvement is you have these lofty goals of outcomes you want to improve, but they're really hard to measure and really hard to measure for an individual clinician. And so you turn to a process measure that often is flawed or can game the system, and you don't know if you're actually impacting care the way you hoped. And I'm proud to say that eventually UCSF, you know, in addition to this checkbox, made it part of the workflow for respiratory therapists to see all patients who were identified as smokers by the nurses and do counseling and offer them aids and hotlines. And we eventually got our act together and did it right. But so many places are hamstrung by this idea of it's really hard to measure the outcomes, and the outcomes are really challenging to attribute to an individual provider and are filled with confounders. And so we go to process measures, which are easy to game and don't always tell us whether we're providing the care that we want. On a national level, we have done this too. We've moved largely in our value-based purchasing from process measures to outcome measures. You'll see that in 2013, our value-based purchasing, that's the money the government gives to us to take care of Medicare patients or gives to us if we achieve certain quality measures to take care of Medicare patients, that when we first started, 70% of these were core measures. Do you remember core measures? They're like, did you give an ACE inhibitor to your AMI patient, and did you give antibiotics within 4 hours in the ED? And we recognized that just because you gave that ACE inhibitor doesn't mean that patient took it, and doesn't mean you prevented heart failure or improved their heart failure. Those are the outcomes we cared about, but we were stuck on giving ACE inhibitors. Or just because you actually managed to give a pneumonia patient antibiotics within 4 hours, how many other patients got antibiotics within 4 hours who didn't need antibiotics? And this is the real challenge with process measures. They're super well-intentioned. Do I want to give ACE inhibitor to everybody with heart failure? Yes, I do, but it doesn't end there. And we really have tried to move in the direction, as you'll see in 2018, we've tried to move in the direction of paying for quality outcomes, looking at the outcomes of patient experience, safety, there should be mortality up there, and efficiency, which is Medicare spending for beneficiary. And so we're starting to think about paying for these right things and paying for the outcomes. These outcomes, though, when you put them in front of people, it's really hard to make things resonate. It's really hard to make, this is our True North card for UCSF. But when people look at it, it's really hard to say, 30-day readmissions. How do I tie what I'm doing today and how hard I am working today with that number that I see on the screen? Oh, mortality, but I was really proud that I made a really good death for that family, that I counseled them that they probably didn't want to go through another round of chemotherapy, and that now it was time to, rally around the patient in their terminal illness and find a really peaceful end. How is that in my mortality scores? How is that looking at me as a reflection of how I perform? And so we have this challenge of process measures that may inadequately address the outcomes we really care about, but then sometimes when we look at these really big outcome measures, they just don't resonate with our providers. And I think that's something we really haven't found a way to effectively navigate as we think about quality improvement, but I will give you some ways that we can move forward on that. So my first piece of advice, some of the external measures are truly important. And you can look at smoking cessation counseling and say, yeah, well, that's just a checkbox measure. Or you can say, yeah, at some other hospital, it's a checkbox measure. But here, we're realizing that smoking cessation counseling is really the first step into people quitting smoking. So I'm going to just throw the full weight of my quality improvement armamentarium behind that and make it more than just a simple process measure. And then I will remind you, you guys are at Emory. People listen to you. You guys are much closer to Washington, D.C. in proximity than we are at UCSF, and you guys have power. You have a voice. You can actually affect the quality measures that don't make sense to you. Do important things that aren't externally measured. So find what resonates with your doctors. When you talk to them and you say, I want to improve quality, what does that mean to you? In our department, we are, and this is part of my Department of Medicine role, we are building PRISM. It is performance improvement through strategic measurement. And rather than putting mortality and readmissions, we're saying, what are the pillars that are important to our physicians? People, patient care quality, research scholarship, education, strategic growth, and university and public service. And within those goals, what do you want to see changed? What do you want to be able to measure? So I'll give you some example of things that we're measuring in these pillars. So for people, we're looking at time spent in the EMR per RVU, or time spent in the EMR per half day of clinic. And we're saying, well, that is what is really important to our people, the time they're spending in the EMR and the time they're spending in the EMR in off hours. So if we can find a way to capture that and to reach out to people who we can see are really struggling with the inefficiency of the EMR and give them at the elbow support through our EMR support team, we will have gone a long way. That is how we will know that our people are thriving when they're spending less time in the EMR per patient they see. Or also under people, we're starting to measure net promoter scores. That's the number of people who say that they would recommend this place to friends or family, give it a 9 or a 10 as a place to come for work and as a place to come for care over the people who would give UCSF a score of 6 or less. And how are we feeling about both this is a place to come for work and a place to come for care, and really doing improvements around that. So for patient care quality, some of the things we're looking at are code blues on the floor. That's not on any measure, but I think everybody can argue that that is an outcome measure that looks at our failure to rescue patients much more importantly than looking at their mortality and even their risk-adjusted mortality. We're also looking at consult timeliness, which is that both that synergy between people and patient care quality of how quickly are people getting their consult notes. Or when a consultant sees a patient in-house and says that they should follow up in their clinic and says, oh, don't worry about it, I'll take care of it, I'll make sure they follow up in clinic. Is that actually happening? And in what time frame? And what happens to that patient in between? So we're really trying to say, we have amazing analytic abilities through our EMR. Why stick to these tried and true outcome measures when we can look at the processes that we are concerned about at our institution and put some of our best analytic minds to saying, well, how do we figure that out in the EMR? How do we create, how do we define consult timeliness? What are our expectations? And how do we start to measure those things? Or for research, people are tired of, impact factor of your journals. So we are mining PubMed open source to look at the number of citations your publication has and looking at ways to reward collaboration, the people who always include other people from our institution in their grants or who publish papers where they're not the only paper from their institution on the paper. And really looking at things, those unmeasured things of collaboration and cooperation and professionalism that don't come out in the generic quality measures, but really come out when you're saying, is this a place where I want to work? Is this a place that has its heart in the right place? And I would also encourage in this to think about the mode of feedback. We struggled and have gone everywhere from individual scorecards to it's wrong to feedback individual data and everywhere in between. And really where we've ended up is that medicine is a team-based sport. And as much as we can provide team-based feedback, both ancillary staff and providers included on that team for things like discharge by noon or things like, how good of a quality was the discharge paperwork that you handed to a patient. So we did a randomized control trial that was published in BMJ looking at how do you deliver that feedback in a way that really resonates with people. And what we found is that individual feedback felt punishing to people, and it felt people automatically developed walls when seeing their data reflected back to them, and it challenged them in a way that often made them defensive versus providing in a team-based way had that recognition that we were all in this together and we should have team-based performance improvement. I will say that was true only when people felt they understood the why behind the metric, and this really speaks to the importance of marrying that education about the why with the mode of feedback and really thinking about, are you making that thing that you want people to do the easy way to do it through systems change. Great. And then my last point would be just wait. We're just getting started on how to measure things better. And one thing I'm really excited about is the rapid expansion of patient-reported outcome measures. Right? You want to know not did I get the diuretic right and was my patient readmitted, but you want to know, did my patient feel well for the time they were at home? You want to know, was it really easy for you to go get your medicines, or did you get a lot of hurdles? So patient-reported outcome measures really look at the value of our care to patients in terms of their quality of life and their symptoms, and there are now more and more evidence-based questionnaires that we can give to patients to look at the value of our care, not in the terms of costs or efficiency or patient satisfaction scores or mortality or readmissions, which is all the ways that Medicare is measuring it now, but those are all financial measures. That Medicare cares about readmissions and efficiency, Medicare cost per beneficiary and mortality. A little bit selfishly, I want to ask, well, what was the value of my care to the patient? Did I deliver care that mattered to them? And really looking at patient-reported outcome measures, functional status, symptom scores are really going to allow us to do that. At UCSF, we are now just starting to deliver patient-specific questionnaires in the palliative care setting, in rheumatology clinic, and in GI clinic, looking at patient symptom scores on how they're doing after interventions. So we've got 3 of our 4 pillars now. We almost have a full stool. And to think about the last pillar, I want you to think about, how do we actually change provider behavior? Can we really control people as much as we thought we could? And I think early in this quality improvement journey, we thought, oh, well, if we can just teach them what to do, that is a way of control. Or if we can just give them an alert, we can control them. But as every parent knows, you cannot control your children, just as we cannot control all the doctors in all the hospitals that are under Emory care. And so this idea of controlling our environment and that way improving quality is not going to be successful. My favorite thinker about how we need to think about problems in healthcare is realizing that healthcare problems are not technical problems. They're not problems that have one right answer. Instead, as Ronald Heifetz says, healthcare problems are adaptive problems. And adaptive problems are problems that require people themselves to change. And thus, people are the problem, and people need to also be the solution. And quality improvement then is about mobilizing the people and engaging them to solve the problem rather than just trying to anesthetize them and telling them how you're going to solve that problem for them. And so instead of thinking about control, I want us to instead really think about influence. How do we influence people through our behaviors, through our role modeling, through the messages we give them as leaders, through the barriers we break down? When we say, hey, this is such an important problem, we're going to change the EMR to address it, or we're going to put in a new staff person into your clinic to help manage that. That is the message we're sending them, and through that we are influencing their behavior by telling them this is important. We also need to recognize everything else that is going on in their universe, the gravity that is, a part of living on Earth, and recognizing that they are living in a sea of other competing pressures. And as we come down with our quality improvements, having a sense of what else is going on in the world that may be impacting the way they provide care. And again, going back to our educators analogy, we have been doing the sort of Ebbinghaus forgetting curve of QI, but instead we need to ask ourselves, well, if I really want people to change behavior, how am I reinforcing what I've just taught them so that my learning curve of the right way to do things doesn't suffer a decrement? How do I then, change the EMR for them so they get that reminder of, oh, right, I heard that we were trying to change the way that we schedule screening colonoscopies. And then how do you provide them feedback then on how they've done at scheduling screening colonoscopies? And then how do you again have, a mentor sort of sit down with them and review their performance with them? And so there need to be multiple touches on these things that we think of as big problems if we're really going to have any sustainable change in performance, just as we recognize as educators we need multiple touches with a topic before we're going to sustain that knowledge. So we now have our 4 pillars of our quality improvement stool. Again, I would argue without which our quality improvement efforts will likely fail. Education on why this matters and how we hope to address this problem together. Data audit and feedback, finding those valid measurements, those measurements that resonate with people and say, yes, this represents the quality of care that I would like to provide, and provide feedback at the level, often team-based, that people need to see it. And then really thinking about new workflows, often within the EMR, but remembering that new personnel can often be the key to reducing resource use and improving patient outcomes, making the right thing the easy thing to do. And then culture change, making people part of the solution and really contributing short-term wins. And it's really through those things, through all those reinforcements, that we start to create a new narrative around a problem. And when you find people talking differently about a big problem, as we have all seen nationally with the opiate epidemic, people are starting to talk about this problem with new language and new gravity and come up with new solutions, because it has been hitting us, the problem has been hitting us from all sides. And when people start to do that and they start to talk about a problem and come at solutions from all angles, it really builds a new narrative about the problem and the way that we want to solve it. And this is my favorite quote. In his Frenchy way, Jacques Derrida said, "Everything is arranged so that it be this way. This is what is called culture." And when we approach quality improvement through this multimodal way and give the problem this new narrative about how we're going to solve it, our culture as an organization and how we care about that problem and the attention that it gets starts to change. So a couple reasons in the last 3 minutes of my talking, and I want to save time for questions, of why I'm optimistic about quality improvement is this is an incredibly young field. We have been doing clinical research, and having a lot of failed trials for a long time. So I'm going to give quality improvement in its first 20 years a little bit of leeway. And when we are starting to see impact, and these are some studies that have been published in the major journals around readmissions and IPATH and diagnostic errors and advanced care planning, and you look at all the things that we've changed, we have made amazing clinical impact for our patients. The other reason why I'm optimistic is because measurement is going to get so much better. We are getting so much better. We are getting so much better about measuring the true quality of care that we provide. Risk adjustment is getting better. We're focusing increasingly on social determinants of health, both in our risk adjustment and in our interventions. And we're having more focus on the evidence against low-value care and more focus on patient-reported outcomes. Now, the journey forward is not going to be easy. But when I think about what is going to help us most in this journey, I turn to a quote from a fabulous iconographic book, Zen and the Art of Motorcycle Maintenance, who's, as they're taking a motorcycle ride across the country, the narrator's son asks him, well, is it hard? And he replies, not if you have the right attitude. Having the right attitude that's hard. So I think what I worry most about in our journey to improve quality is actually our physicians' appetite for quality improvement. And I worry about how are we going to improve quality in this time of rising physician burnout. Don Abedian, on his deathbed, when asked, he was one of the founders of quality improvement, and when asked what he thought the secret to quality improvement is, he shared that he was really worried about this industrialization of QI, this mechanistic framework of, oh, you just have to, make your fishbone and do your process map. And he said, I feel like we've gotten too far into the theory of QI when really what quality improvement is about is, he said, the secret of quality improvement is love. And you really have to love your patient and love your profession, and the rest will follow. And so I think one of the things that I would love is if we can somehow make quality improvement the antidote to burnout. If we can figure out a way to make our systems work for the providers that practice in them, when you feel confident that that referral you sent to clinic will actually result in the patient being seen, when you are not scared that your patient will not get the access that they need to a life-saving event, when you are struggling with multiple alerts in the EMR that seemingly are not tailored for your patient, all of that contributes to physician burnout, and it decreases our appetite to do QI, which then makes the system more inefficient, which then increases burnout. And I think doing QI well and improving our process can be a great antidote to burnout. And I said I encourage all trainees to ask people they meet, what do you do every day, and do you love it? And so I will tell you, that's what I try and do every day. I try and make the system better so physicians can be happier practicing the medicine they want. And yes, I love it. So I will leave you with this poem, which I think when we think about burnout in medicine, I think we are so privileged to be able to do what we do every day, to be able to interact with the people we interact with and try and make their lives a little better and their health outcomes a little better. We need to make sure that this is a place and a work in which we can find fulfillment. So thank you all for your time, and I'm happy to take questions.
Questions for Dr. Mourad? Bill, I knew you'd have one.
That's great. I really enjoyed it. So your chair, Bob Walker, wrote a provocative piece in the New York Times a couple of years ago now, I guess, suggesting that excessive quality measurement was robbing the humanity of both teachers and doctors, that we ought to consider scaling back. I was kind of surprised, and I wrote a letter in response that I didn't publish, suggesting actually the problem is that they're the wrong measures and they're too hard to collect, and maybe accelerating is the right response. And I'll talk to Tim about it some, but what are your thoughts? My take from your talk is that you wouldn't recommend that we measure less exactly. I would love to hear how you're thinking about this and how you and Bob are thinking about it together.
Yeah, and thankfully, as the vice chair, he delegates all of the QI measurement and dashboards and scorecards to me, so I get my prerogative here. And I think I do align a little bit more with you in this. I think that experience of being confronted with your data and challenging what you believe to be your performance is essential, but I do think we have had so many false starts with what are the right measurements. Is it process measures? Is it outcome measures? That people now look at measurement and they say, I'm just going to throw the whole thing out because this doesn't reflect what I know to be my strengths as a doctor. So I do think we need to iterate and iterate quickly and interact with people around measurement more. It's not enough to put a scorecard in front of people. It's sitting down with them and asking, hey, what in these quality measures feels important and impactful to you? I was terrified for years to put readmissions in front of our hospital medicine group because 30-day readmissions just felt like an ocean of care that happened after their care and why should they be responsible for. And this year they finally came back to me and they were like, we would like 7-day readmissions to be on our scorecard. We have chosen this, not the institution. We have chosen this as something that we feel like is valuable and actionable. If you provide us with these process measures of readmissions, how many patients went to skilled nursing facilities, how many. So they said, we will own that outcome measure if you give us these process measures that went with it, and if you can slice and dice the data this way. And it was such a collaborative experience for how they wanted to see that outcome measure. And I was like, that's where we need to go to. And it just takes more time than all of us have in our day, is to really ask physicians, what about this measure doesn't feel meaningful? How can I make it more meaningful? How can I tell you a little bit about the why we created that measure, and then put it in front of them after that? So.
Thank you very much for your talk. I'm one of the third-year residents in internal medicine. I'm David. I just had a question about, I was curious to speak more about the patient-related outcome measures, how they are typically collected, either at UCSF or otherwise, and if any technology is used.
Yeah. So this field is pretty early. There is something called PROMs, which is a national body that has come out with validated surveys that we can use to look at symptom scores and functionality. And so these are now in a bank for people to use and either use out of the box or adapt. And many EMRs are now delivering the capability to deliver these, say, through your patient portal prior to a visit, after a visit, at scheduled time points throughout the year to measure a patient's symptoms. And the challenge that we're struggling with at UCSF and why we've slowed our implementation is we want to make sure that patients aren't suddenly being bombarded with these questionnaires which we think are really going to help them. And they are like, gosh, why won't my doctors leave me alone? So we are implementing slowly and carefully and trying to say and trying to figure out how do we actually message to them and create a campaign to them that say, this is going to be our way to know that we're doing the right thing by you. And so if you just Google PROMs without the E, you'll find that a wealth of resources about patient-recorded outcome measures, and you can click on links to some of the surveys. Sure. Okay, great. Thank you all. It was a pleasure to speak to you today.
Thank you for coming. Dr. Mourad is going to join us in our annex offices for some more informal conversation. Anybody who's interested, welcome to join us. Thanks.